Good morning and welcome everybody to our ILAE webinar for today on febrile seizures. It is my pleasure to introduce Dr. Charles Hammond, a pediatric neurologist from Ghana, who will be taking us through today's session. Welcome, Dr. Hammond.
Hello, everyone. My name is Charles Hammond, and today we'll be talking about febrile seizures. So the objectives of this lecture are one, to define febrile seizures, and then the type of febrile seizures, and to discuss the biologic basis for febrile seizures. We'll also attempt to outline the risk factors for the first febrile seizure and the risk factors for recurrence, as well as the risk factors for subsequent epilepsies, and then also outline the approach to the child who is presenting with febrile seizures. We'll start first with the definition. Febrile seizures have been defined consistently as seizures occurring between the age of 6 months and 5 years, some authors will say 6 years, associated with fever, but without evidence of intracranial infection or inflammation. As I said earlier, some authors have used different age ranges, such as 3 months to 5 years. Some have used 6 months to 6 years. The most important thing is that it is age defined. There has to be fever, and then there has to be no evidence of intracranial infection. So the event or the seizure is usually a brief generalized tonic-clonic seizure, but it may be focal. And when I say brief, I'm talking about less than 15 minutes. And it may be focal in up to about 8% of patients. And then about 5% of patients may have prolonged prolonged seizures, or seizures may be lasting longer than 20 minutes. Again, the fever or the body temperature is usually high, typically above 38.5, but some authors have quoted 38.3, some have quoted 38.0 degrees Celsius. There are various scenarios of children presenting with fever and seizures. So it may occur under various circumstances. And the first one we want to talk about, or the first category of such scenarios, is the child who is presenting with fever associated with seizures associated with fever. And they typically have only seizures and fever. And in the first, it's usually in the age range of 6 months to 6 years. Then there are those who present with fever and seizure from 6 months to 6 years, but subsequently will have a febrile seizure. So we say they have epilepsy following the febrile seizure. Then those who will have epilepsy, but presenting in the first few months with febrile seizures, and then they may have afebrile seizures in between. But beyond 6 years, they don't have febrile seizures. Then we have those who will also have first afebrile seizures, and then these seizures are triggered by fever. But beyond 6 months, they continue to have afebrile seizures. And then there is also the fifth category, not represented on this diagram, which will be patients who continue to have febrile seizures even beyond the, or fever with seizures even beyond the cutoff age of 6 years. So other events may occur with fever, and it is important that we distinguish between these events and febrile seizures. And they include events like rigors, febrile delirium, febrile myoclonus. Some syncopal attacks may occur with fever, and it is important that they are carefully excluded, and that the appropriate management is offered. Some illnesses may be related may have seizures as part of the illnesses, but not necessarily fever. For example, some diarrhea diseases or diarrhea illnesses may present with seizures, even in the absence of fever. The presentation is similar to febrile seizure. They are typically brief. They have the same age range, and many of these children will experience febrile seizures also. And then we have epilepsy syndromes that may present with febrile seizures. Typically, we have the genetic epilepsy with febrile seizure plus, and then the Dravet syndrome, also known as the severe myoclonic epilepsy of infancy. And we'll talk about these later on. Next, we want to look at the biologic basis of febrile seizures. And we know that it is related to three key things. These are the immature brain, and then fever or infections, and then genetic predisposition. Talking about the immature brain, it is closely linked with myelination. We know that during myelination, or it has been postulated or hypothesized that during myelination, there is a dying back of excessive neurons, and then there is also increased synaptic connectivity, making the brain highly excitable during that period. And this probably explains why the age range of 6 months to 6 years. We know there is very little myelination before 6 months, and then after 6 years, there is almost no myelination. So this hypothesis sometimes is used to explain why febrile seizure has that age-related susceptibility. Next is the fever. Infections such as upper respiratory tract infections, pharyngitis, otitis media, malaria, gastroenteritis, pneumonia. These are very common infections in children, and they are commonly associated with fever, and then also with febrile seizures. And vaccinations, especially with the whole cell DPT and then the whole cell measles vaccines, which were previously used in many countries, tend to generate fever, and these will also cause febrile seizures sometimes. It has been noted in some studies that up to 9%, up to 9 per 1,000 children, 100,000 children receiving the DPT, and then up to 25 per 100,000 children receiving the measles vaccine had febrile seizures. Currently, most of these vaccines have been replaced by the acellular type, and we are seeing a decreased incidence of seizures post-vaccination. So the fever, we know, activates the cytokine networks, leading to the production or increased circulation of interleukin-1 and alpha and 1 beta, and this will ultimately lead to increased neuronal excitability. Again, the fever may lead to respiratory alkalosis, increasing cortical pH, and this increases neuronal excitability again. Then the immaturity of the thermoregulatory mechanism in the young child has also been cited. And then again, some studies have said that there is a decrease in serum and CSF zinc levels in children who are presenting with febrile seizures. And we know zinc is an important modulator of GABA synthesis. So the decreased concentrations actually leads to poor regulation of GABA synthesis, and that may lead to febrile seizures. The last thing to consider is the genetic predisposition seen in children with febrile seizures. There is a complex inheritance pattern, and many genes and environmental factors are involved. It is noted that monozygotic twins have a higher concordance rate as compared to dizygotic twins. And the possible modes of inheritance has been polygenic, but again, autosomal dominance inheritance has been identified. And in this children with autosomal dominance inheritance, there is reduced penetrance. What it means is that not all children who inherit a particular mutation will express the phenotype. There are more than 7 chromosomal loci which have been associated with febrile seizures. And very common ones are the mutations in the sodium channel N1A gene, SCN1A gene, SCN1B, SCN9A, which have been commonly associated with genetic epilepsy with febrile seizure plus, and then also Dravet syndrome. So next, we want to look at the first febrile seizure. What are the factors associated with the first febrile seizure? The risk of a first febrile seizure is increased in any child who has delayed neonatal hospital discharge. These are from studies done in the early 1990s. If any child has delayed neonatal hospital discharge, that child is at an increased risk of having a febrile seizure. Any child with slow neurological development as judged by the parents. And again, the study also said that if you have a first-degree relative with a history of febrile seizure, you are at increased rates of febrile seizures. Again, they looked at second-degree relatives like uncles and aunties with febrile seizures. And then that also increases the rates, but not as high as when it is a first-degree relative. And again, attendance at a daycare also increases the rates of the child having a first febrile seizure. And that is quite understandable because most of these viruses are circulated and shared amongst the children attending daycare. We want to try to make the distinction between simple febrile seizure and complex febrile seizure. A febrile seizure is said to be simple if it is generalized, it presents as a short seizure, and short we usually say less than 15 minutes. If you have only a single episode in a 24-hour period, or some authors will say during the whole febrile illness, you have only a single episode. That also makes it a simple febrile seizure. And simple febrile seizure typically will have no post-ictal brain damage, and then the children tend to have a normal psychomotor development. As compared to the complex febrile seizure, which may present as focal or generalized, and then they tend to have prolonged duration more than 15 minutes, and then they may have more than one episode in a 24-hour period or within the same febrile illness. And then the complex febrile seizure also tends to have post-ictal neurological abnormalities, including thought paralysis. What is important here is that if you have just one of the features describing the complex febrile seizure, it makes the seizure a complex febrile seizure. So you may have a generalized seizure. It may be of shorter duration, but if you have more than one episode in 24 hours, or if you have even one episode, but it's greater than 15 minutes, that makes it complex. If you have a short seizure, single episode, but it is focal, that makes it complex. And then if you have a short seizure, which is presents as generalized, but later gives you a thought paralysis, then you know that actually it has a focal onset, and that makes it a complex febrile seizure. So when to admit and when not to admit is a very important question that we need to address. Hospital admission is required for any child less than 18 months old presenting with a first febrile seizure, whether simple or complex. So if it's a simple febrile seizure and the child is less than 18 months, this child needs to be admitted and monitored in hospital for up to about 24 hours. If it is a complex febrile seizure, then it doesn't matter the age of presentation, that child must be admitted to hospital. If the seizure required pharmacologic intervention before it stopped, then that child should again be admitted to hospital for further evaluation. And then if again the witnesses are not reliable, the eyewitnesses or the parents cannot give you a reliable history or reliable eyewitness accounts, I think it's proper to admit such child into hospital. And again, if you have no identified focus of infection, then it's important to admit that child for further workup. And then again, one common reason to admit the child to hospital is where there is high parental anxiety. It is important to know that hospital admission is not necessary if the child is presenting with a first simple febrile seizure and that child is older than 18 months of age. Again, if the child is presenting with a recurrent simple febrile seizure, that child does not need to be admitted, especially if the focus can easily be identified and appropriate measures put in place. Next, we want to talk about recurrence of febrile seizures. About 30 to 40% of children with their first febrile seizure will have at least one recurrence. So it's important to discuss this with their parents. The risk factors for recurrence are a child presenting at a young age, that is presenting with the first febrile seizure at a young age. And usually that is less than 15 months of age. Some authors have quoted 18 months of age. If there is a family history of febrile seizure in a first degree relative, that also increases the risk of recurrence. When the first febrile seizure occurred at a relatively low temperature, that is also a risk factor for subsequent febrile seizures. And again, when the duration of the onset of the seizure and the fever, the onset of the fever and the onset of the seizure is of a short duration. So when you have a short duration of illness prior to the seizure, that is also a risk factor for recurrence of the febrile seizure. If you have none of these risk factors, then the risk for recurrence is about 4%. But if you have one of the risk factors above, then the risk is about 23%. The risk increases as you have more risk factors. So it increases to 32% if you have two of these risk factors, and then to 62% if you have three, and then to as high as 76% if you have all four of these risk factors. Let us note that having a complex febrile seizure and having neurological dysfunction are not consistent predictors of recurrence. So they do not predict that there could be recurrence of febrile seizures. But we will talk about subsequent epilepsy, and that is when complex febrile seizure becomes important. So the risk of subsequent epilepsy, we just talked about the risk of recurrence of the febrile seizure. Now we are talking about the risk of subsequent epilepsy. So for children with simple febrile seizure, it is estimated that they may develop epilepsy or they may have epilepsy later on in life at just slightly increased rates than the normal population. So the risk of epilepsy is estimated to be around 1 to 1.5%, just slightly higher than the incidence in the general population, which is 0.5%. Then the risk of subsequent epilepsy is then increased if the febrile seizure was a complex febrile seizure or had complex features, such as being focal, such as being prolonged, or having repeated episodes within a single illness. Again, if the child has developmental delay or neurologic dysfunction, that again increases the risk of subsequent epilepsy. And again, if there is a family history of epilepsy, that increases the risk of epilepsy in the child presenting with a febrile seizure. The number of febrile seizures is not a predictor of epilepsy. So some children could have 4 or 5 febrile seizures before they turn 6, but will not go on to develop epilepsy. The risk for developing epilepsy is based on if the seizures were complex, if the child had developmental delay or neurologic dysfunction, and then if there is family history of epilepsy. We have recently from the FEBSTART study, we know that prolonged febrile seizures will lead to hippocampal sclerosis, and that may lead to temporal lobe epilepsy in some children. The next most important things for us clinicians is evaluating the child with a febrile seizure. So the clinical evaluation should include a thorough history from a reliable witness. Most often it's the parent, but it may be a nursery attendant, it may be a school teacher. So having a thorough history from a reliable witness is important. A thorough neurological examination, especially to look for focal neurological deficits, and then other neurological features like neurocutaneous lesions are important to look for. And then a systemic pediatric examination, very, very important in children presenting with febrile seizures. You may have to look at the ears and then the throat, because these are common focus of infection for children presenting with febrile seizures. Routine blood work is usually not recommended. However, you may do them to aim at identifying the cause of the fever, and they may include things like the full blood counts, serum chemistry or blood chemistry, and blood cultures, which are not routinely indicated unless you think there is a bacterial infection. However, let me say that in malaria endemic regions like ours, it is important to look for malaria parasites either by doing a peripheral film comment, a peripheral film for malaria parasites, or the rapid diagnostic test for malaria parasites. The lumbar puncture is controversial. So in children presenting with febrile seizures, the lumbar puncture should be performed if there are meningeal signs and there are no contraindications. So in that case, you need to perform a lumbar puncture if there are meningeal signs. But we all know that if you are thinking meningitis, children will not usually have seizures and recover when they have meningitis within that short period. They have seizures, and then they may have neurological deficits in the post-ITA period. But however, if there are meningeal signs, then you need to consider lumbar puncture. That is, if contraindications have been ruled out. Again, if the child has been previously treated with antibiotics during that febrile seizures, during that febrile illness, before the onset of the seizures, then you need to consider lumbar puncture. It should actually be performed. This is because the prior treatment with antibiotics could have masked the meningeal signs, and you may not pick them up. Again, the recommendations are that for children less than 12 months presenting with a febrile seizure, the lumbar puncture is strongly considered. You should strongly consider it. However, for children 12 to 18 months, it should be considered, but they should carefully be observed in hospital for up to at least 24 hours. This is because these young children, up to 12 years, up to 12 months, up to 18 months, they may not have clear meningeal signs. That is why you should consider the lumbar puncture. But for older children, beyond 18 months, the lumbar puncture is not routinely warranted, and that you should consider it based on individual basis. The next thing to consider is neuroimaging. Routine neuroimaging, especially in resource-poor settings, is not indicated when the child presents with febrile seizures, whether simple or complex. It should only be considered when a structural lesion is suspected, such as children presenting with focal neurological deficits, or children having significant developmental delay, or children with neurocutaneous lesions. And some children with abnormal head circumference, whether micro or macrocephaly, should have a neuroimaging done. The EEG, which is one of the commonly abused tools, is not indicated following a simple or complex febrile seizures. But some authorities have recommended the EEG based on its diagnostic yield in conditions like viral encephalitis, which is also a very common cause of febrile seizures. Next, we want to consider the treatment of the child with febrile seizures. The key steps should include stopping the ongoing seizures, addressing the cause of the fever, and then dealing with the parents' fear or anxiety. So most febrile seizures will last only a few minutes, usually up to 3 minutes or even less. And that by that time, the child has not even arrived in the emergency room. But if the child presents to the emergency room with ongoing seizures, then it is safe to assume that the seizures have been going on longer, especially in our part of the world where emergency response is not so swift. It may take longer for the child to arrive in the emergency room. So for any child arriving in the emergency room with ongoing seizures, it is safe to assume that the seizures have been going on for more than 15 minutes. Usually at this time, parental account is not reliable because when your child is having a seizure, even 1 minute will look like 10 minutes to you. And so when they come, they usually think the seizures have been going on for hours. But it is safe to assume that it's been going on for more than 15 minutes when they arrive with ongoing seizures. So in the hospital setting, the initial safety measures should include checking for the airways, looking for airway patency, securing IV access. You have to monitor vitals such as heart rate, respiratory rate, the oxygen saturation, and the blood pressure, and then administer oxygen if the blood pressure is less than, if the saturation is less than 90%. And then you have to stop the ongoing seizures with benzodiazepines. And commonly we use rectal or IV diazepam. You may also use rectal or IV lorazepam or buccal or nasal midazolam if that is available. And it's important to check blood glucose and correct hypoglycemia if it is present. Because of the risks of acidosis, you have to monitor the base SS and treat electrolyte imbalances appropriately. And then if the seizure does not stop, you have to refer to the status epilepticus protocol, which would typically involve a second line drug like phenobarbital or levetiracetam or sodium valproate. In some instances, phenytoin or even paraldehyde may be used, and then a third line using anesthetic agents. It is also important to identify and treat the underlying cause of the fever, and this may include different steps based on the clinical suspicion. The local guidelines should be followed. Okay, so for example, using a rapid diagnostic test or blood film to look for malaria parasites, and then treating with anti-malarials. The other controversial topic when it comes to febrile seizure is the use of antipyretics. So if the fever persists, then antipyretics are indicated. However, there is no evidence that the use of the antipyretics prevents recurrence during that febrile illness. So you may use antipyretics effectively, but some patients will still have recurrence during that febrile illness. Also, there is no evidence that the antipyretics prevents subsequent recurrence of febrile seizures. So some parents would want to give antipyretics. They come and tell you that they've given antipyretics right at the onset of the seizure because of their previous experience. They'll give antipyretics right at the onset of the fever, and yet the child goes on to develop a febrile seizure. But it is important to note that the antipyretics render the febrile child comfortable. and that probably that is their only use, their main role in the treatment of the child with febrile seizures. That is rendering them comfortable. Again, it is important to deal with parental fear and anxiety. During a febrile seizure, most parents think their child is dying. And then after the seizure, they are worried about recurrence, whether during the same febrile episode or during subsequent febrile episodes. And some also have fears about subsequent epilepsy. Such fears and anxiety should be properly managed alongside the treatment of the child. And then the parents want to discuss prevention of recurrence and subsequent epilepsy. And so we shouldn't ignore that. So what do we tell them when they bring out the issue of preventing recurrence and subsequent epilepsies? So first, the AAP does not recommend prophylaxis for simple febrile seizures. And then again, the use of continuous prophylaxis such as phenobarbital or valproate in preventing recurrence of simple febrile seizures is controversial, especially because the risks far outweighs the benefits. And again, some authorities will use intermittent rectal or oral diazepam as prophylaxis. When the child has a febrile illness, they will give rectal diazepam. This is again controversial because the risks outweighs the benefits. However, prophylaxis may be considered for patients who are having frequent febrile seizures in a short period of time. And when I say short period of time, I'm talking about having about 3 or more episodes in 6 months or 4 episodes in 1 year. Again, patients who have history of prolonged febrile seizures, seizures that are lasting more than 15 minutes, we need to provide them with rescue medication. But again, it's important to know that you can only do this if the parents are reliable, because giving them benzodiazepines to use for a parent who is not reliable could be quite a dangerous tool at home. And there is no evidence that these therapies will actually prevent subsequent epilepsy. So whilst they will prevent recurrence of the febrile seizure, they may not prevent subsequent epilepsy, or there is no evidence that they will prevent subsequent epilepsy. Parents again want to discuss a long-term cognitive and behavioral outcome. And it's important to let them know that febrile seizures are benign and they do not impair the academic progress of the child. They do not affect the intellectual or the behavioral outcome of these children. There are some epilepsy syndromes that present with febrile seizures, and you want to know about them. So commonly we have the genetic epilepsy with febrile seizure plus, previously known as the generalized epilepsy with febrile seizure plus. The name was changed to genetic epilepsy with febrile seizure plus because it was noted that there could be focal presentations also. These syndromes have familiar epilepsy syndromes, and they tend to have autosomal dominant inheritance. We already talked about the SCN1A mutation, the 1B mutation, and then the 9A mutations, which are seen in some families. And then others, or they may have variable phenotypes. But the core feature is that there is predisposition to seizures with fever. And these children tend to have a lot of seizures. Some may have seizures even beyond the cutoff age of 6 years. And that is why we also sometimes tend to think that it is a spectrum. So this GES plus spectrum, the phenotype spectrum may have some children will present with just simple or just febrile seizures, and others may have febrile seizure plus. So these ones have febrile seizures that persist even beyond the cutoff age of 5 to 6 years, whichever you'll be using. And then they also tend to have afebrile seizures. And then at the extreme end of the spectrum are children who have Dravet syndrome, who will initially present with prolonged febrile seizures in the first year of life. Very catastrophic, may end up in ICU or may spend lot of days in hospital. And then in the second year of life, they tend to develop myoclonic seizures, which are medically intractable or refractory to treatment. And then they have very bad cognitive, behavioral, and developmental outcomes. So in conclusion, febrile seizures are one of the commonest types of seizures in children. They do not have a long-term impact, usually do not have a long-term impact on the child's development. Most children will not have recurrent febrile seizures. Most children will have only one febrile seizures in their life. Most children do not develop epilepsy, although the risk of epilepsy is slightly increased in children with febrile seizures than in the normal population. Anti-seizure medication for prophylaxis is not usually required. Rescue medication should only be provided for children who have prolonged febrile seizures. So I think we'll end it here. Thank you very much. And then we'll have a discussion and answer your questions following this. Thank you very, very much for your attention.
Thank you. Thank you, Dr. Hammond. Due to technical hitches, I will be the moderator for today's session. My name is Dr. Maureen Njoroge. I'm a neurologist from Kenya. I'll take this opportunity to reintroduce Dr. Hammond. I realize we didn't do his introduction justice. So Dr. Hammond is a consultant pediatric neurologist from Comfort Anoke Teaching Hospital. He is a senior lecturer, Department of Child Health, School of Medicine and Dentistry, at the Kwame Nkrumah University of Science and Technology from Kumasi, Ghana. Thanks again for the wonderful presentation. We'll go through some of the questions. So you have one of the questions, someone is asking, could you elaborate more on post-ictal neurological and psychomotor abnormality? Are there any specifics within the age group? So are there specifics in the post-ictal neurological and psychomotor abnormalities? In terms of
thank you very much. Thank you very much, Maureen. And thanks for the kind introduction. So I mentioned the post-ictal neurological dysfunction, especially with complex febrile seizures. And by that, I mean focal deficits in the post-ictal period. Some children may have cognitive deficits, behavioral deterioration. This does not include the post-ictal sleep that usually you will see following seizures. But when you have focal neurological deficit, like the thought paralysis, then it's important to consider the seizure as a complex febrile seizure. Simple febrile seizures will not leave the child with a cognitive decline or cognitive disability. So they still perform in school, they still do well in school, they're able to learn like every other child. And then they usually do not, for simple febrile seizures, they usually do not have behavioral deterioration. So if you have a child who presents with a focal deficits following a febrile seizure or has cognitive decline or behavioral deterioration following the febrile seizure, that is likely to be a complex febrile seizure rather than a simple febrile seizure. I hope that answers the question. Yeah.
Thank you. Thank you. We seem to be having quite a number of questions. We'll go straight to the next one. So the next question is about what the ILAE definition in terms of the age for febrile seizures is.
Okay, so traditionally it has been 6 months to 5 years. When I was a medical student some 22 or so years ago, we said 6 months to 5 years. More recently, people have quoted 6 months to 6 years. That looks easy to remember. A few authors have also mentioned 3 months to 5 years or 3 months to 6 years. I mean, the most important thing is that there is an age-defined period within which the child is susceptible to seizures following a febrile illness or during a febrile illness. So it's somewhere there between 6 months and 6 years, and some have come down to 3 months. But I think the most recent ILAE paper on definition still talks about 6 months to 5 years.
Thank you. There's a very interesting question about so for how long should prophylaxis be given if indicated, and what would be your choice of anti-epileptic medication?
That is a very tricky one. Looking at the age category within which we are considering this patient as being susceptible. If you choose to do prophylactic treatment, then you probably should go up to 5 years or 6 years, whichever definition you'll be using. But again, if your patient has been seizure-free for 2 years, 3 years, then does it really warrant continuing the medication beyond that? So it's not easy to give a straightforward answer to this. It has to be tailored to the patient presentation. And I think that you should also, if you choose to do this, you should probably seek some expert's opinion also, especially based on the patient's presentation. So there's no straightforward answer. To me, I don't think that I can say do it for 3 years, do it for 4 years, or do it for 5 years. But then you may aim at stopping after 5 years, because the risk of febrile seizures really goes down very, very low after 5 years. Yeah.
Thank you. That's quite true. So the next question from Laila is the same. So I think we've already answered that about when we give. So a question from Rahampi. He says, thank you for this brilliant presentation. The presence of epileptic interictal discharge at a distance from febrile seizures. Is there a risk of seizure recurrence or development of epilepsy? And is epileptic treatment indicated if you find the epileptic interictal discharges?
So usually in low resource countries like ours, we do not recommend the use of the EEG immediately post-ictal because the findings are very predictable. You are most likely to find slow background, delta or sometimes theta slowing. In focal or complex febrile seizures, you are likely to find focal slowing. But then it has been used, the EEG has been used, as I said in the lecture, to look for possible etiologies like viral encephalitis. But then again, from the FEBSTAT study, it was noted that there could be focal discharges, which could possibly suggest increased rates of epilepsy in subsequent years. So that is coming up, but it becomes a very difficult recommendation for us in resource poor settings where the EEG is not readily available. So I do not want us to dwell so much on it, but yes, if you can have it readily available, then you may consider it. And if you see focal discharges, especially in the temporal regions following a febrile seizure, that could possibly suggest mesial temporal sclerosis. And that is a risk factor for subsequent epilepsy.
All right, thank you. So the next question actually is still on maintenance of anti-seizure medications. I think we've already answered that, and also on the age of febrile seizures. So I'll go straight to the question from Olesegun. He asks, for those children with seizures accompanying URTI or acute diarrheal illness without fever, what nomenclature should be used to describe their seizures? Is it febrile seizures?
Yeah, that is, you can't say it's febrile seizures because we do not have fever in this illness. You can say it's illness-related seizures. But then, as I said, presentation is very similar to febrile seizure. They tend to have an age-defined period within which they are susceptible. And then the seizures are brief, mostly generalized, and will probably require the same interventions as we would do for a child with febrile seizures. But then I doubt if we can call them febrile seizures. Going strictly by the definition of febrile seizures, those may not be febrile seizures. And then we've also seen children who present with acute illness. They may be afebrile and then have a seizure, and then some hours later start to develop a seizure. So the thinking is that it is not the peripheral temperature that matters. The peripheral temperature that we take in the armpit or under the tongue doesn't really matter. It is the rate of rise of the core temperature, which is important. So if I wake up in the morning with a temperature of 35.5 and within an hour, it rises to 37, that is quite rapid. And that could in itself trigger a febrile seizure. Even though my temperature is 37, that could in itself trigger a seizure. You wouldn't call it a febrile seizure. But then we are saying that it is the rate of rise of the temperature, of the core temperature, which is most important, and not necessarily the peripheral temperature. And then let us also remember that at the onset of fever, there may be home interventions that may lower the peripheral temperature, making the measurement that we often do quite not reliable, because there could be tepid sponging, there could be fanning, there could be some other means to decrease the temperature. But the most important thing is the rate of rise of the core temperature. And if that is very rapid, that could in itself trigger a seizure.
Thank you. The next question is, would it be right to categorize a child with mixed febrile and afebrile seizures as having febrile seizures?
So, well, yes, if the first episode is a febrile seizure, then that is a febrile seizure. But if subsequently the child has afebrile seizures, then this child probably needs to be diagnosed as epilepsy. So even some definitions will say that once the child has had an afebrile seizure, if there is a subsequent febrile seizure or a subsequent seizure with fever, that is not a febrile seizure, because the child has already had afebrile seizures and has been diagnosed with epilepsy. So it is epilepsy which is easily triggered by fever and not necessarily a febrile seizure. Yes, so I hope you get it. So you can have epilepsy and then it is easily triggered by seizure in a child within that age category. That shouldn't be called a febrile seizure, even though it is still a fever or a seizure with fever. Yeah.
Yes, thank you. And we remember the very well demonstrated graph that you showed us. So the next question is what drug, okay, so the next question is this, I think you've already answered the drug that you'd recommend, that you've already answered. So there's a question from Natalia. She says, thanks for the lecture. Can you please tell me in which cases it is necessary to perform an EEG and what is the optimal duration?
Yes, so the EEG, my opening statement on the EEG is that it is controversial. Its use is controversial. If you have it readily available, you can use the EEG. It doesn't change your approach, your immediate approach to the child in any way. The approach will still remain the same, but some people have used the EEG as or the EEG finding as a marker for infections like herpes, encephalitis, and because it has a distinct presentation. Most likely, post-ictal EEGs will show slowing, and that is very non-specific and will not give you much information. Findings from the FEB STAT study shows that some children with febrile seizures may have hippocampal sclerosis and then go on to have mesial temporal sclerosis. And this will show on the EEG as abnormalities in the temporal region. So if you want to increase the yield of the EEG, we always say that you do it not so far from the seizures. Again, you may have very, very non-specific findings. And if you do not have, the EEG is not readily available, especially a routine recording of 30 minutes may have a very low yield. And so it may not be a very effective tool to use. And again, as I said, it does not change the approach to the child with a febrile seizure. So I do not want us to dwell so much, especially here in Africa, where the EEG is not readily available. I do not want us to dwell so much on the use of the EEG in the evaluation of the child with febrile seizures.
All right. Thank you. The next two questions are also about the duration for prophylaxis, which we've already answered. Thank you. So we'll go straight to the question from Hamdi, and he asks, if a child with a neurological deficit, such as congenital hypoxic ischemic encephalopathy or cerebral palsy, experiences their first febrile seizure, how should the diagnosis of febrile seizure be approached, considering that the neurological deficit could potentially be another contributing factor?
He's absolutely right. So some definitions actually do not, will say that in the absence of a CNS pathology, instead of saying in the absence of a CNS infection. So if you have an underlying pathology and you have a fever and a seizure, it becomes very difficult to call it a febrile seizure. So the febrile seizure we are talking about is that of a child with no neurological or no underlying CNS pathology. So if for a child who already has a pathology within the brain who suffers a fever, it just says that your seizure threshold is decreased. And so the slightest fever could actually trigger the seizure. But that doesn't stop it from also being managed as a febrile seizure, because the management will still be the same. It may be due to an otitis media, maybe due to pharyngitis, maybe due to anything else. In spite of the fact that the child has an underlying CNS pathology, you still have to look for all the common causes of fever and manage appropriately.
All right, thank you. The next question is from Farah. He says, thank you, doctor. He asks, if a child has more than 4 episodes of convulsions in 24 hours with fever, do we still consider that febrile seizures, or do we say has status epilepticus? Yes. Despite was giving, all right, I think the question really is asking about whether if the child has more than 4 episodes of seizures in 24 hours with fever, whether that's febrile status.
Yeah, so if the child is within that age range and the child has 4 episodes within 24 hours, that is a complex febrile seizure. The definition of status epilepticus is slightly different. So if the child has 4 episodes of seizures without regaining consciousness in between the episodes, then that is a status epilepticus. Or if the child has a single episode, which is prolonged and goes beyond 30 minutes, then that is the status epilepticus. So you may have 4 episodes. It may be a status epilepticus if you do not regain consciousness within the episodes. However, if you regain consciousness and you come back to baseline after every single episode, then that is a complex febrile seizure.
Right. I think that takes us straight to the next question about whether rectal diazepam should be prescribed in febrile seizures and what would be the indication.
Yeah, so as I mentioned, it shouldn't be routinely prescribed because the risks far outweigh the benefits. And then having the rectal diazepam in the hands of a parent who is not so reliable could be a dangerous tool to use at home. However, if a child presents with prolonged febrile seizures. All the time he presents with febrile seizures, they are catastrophic. Then you could give the rectal diazepam to use at home as rescue medication, but you need to make sure that you properly educate the parents who will be using it. In some jurisdictions, they have it already prepared in smaller vials, and so you are not likely to exceed the dosage that child requires. But where you do not have it, others may just draw it, because we tend to use the IV preparation for rectal administration as well. And you can imagine having a whole vial, a whole 10 milligram vial or something, and you draw it, give to an 8 kilogram child. That could be dangerous. So yes, if the child has been presenting previously with prolonged and catastrophic febrile seizures, you could give the diazepam as rescue medication, but it should be properly handled. There are other options like the buccal midazolam, and again, also the buccal midazolam and nasal midazolam, but these may not be readily available in our settings.
Yeah. Right, thank you. So the next question, I think, is from Susan, and I think she's trying to figure out whether you had mentioned whether febrile seizures happened again. And I think, yes, Dr. Hammond did say that if you have a first febrile seizure, you can have others. So we'll go to the other one from Kevanya, who asks, if a child has recurrent febrile seizures within the 6 months to 6 years age group, when can you call it epilepsy and start antiepileptics, or you can only call it epilepsy after age 6?
So the definition of epilepsy is recurrent unprovoked seizures. So febrile seizures are actually provoked seizures. So if the child has been having only febrile seizures, then you need to be careful in calling it epilepsy. Because if the child is still within the age range of 6 months to 6 years, then that brain is susceptible to seizures with fever. So you should be careful in calling it epilepsy. If the child ever has an afebrile seizure, then yes, then that child could be diagnosed as having epilepsy. Again, if the child has recurrent afebrile seizures, or if the child has had previous afebrile seizures and then has subsequent febrile seizures, then you know that there is the fever. So the fever only decreases the threshold for seizures. So that child could actually have epilepsy, which is in which the seizures are easily triggered by fever. But for a child who has fever and seizures all the time, who is still within that age range, it may not be epilepsy. It's most likely still a febrile seizure. And if it goes beyond the age range, then you should consider the genetic epilepsies with febrile seizure plus.
All right.
And then the decision, I was saying, the decision to put a child on prophylaxis, I think we already talked about that it should be carefully thought through.
I think the question for prophylaxis keeps coming back. I think we've answered about. I think you've answered about the duration of prophylaxis, but then there's still several questions about the choice of anti-epileptic medication that you would consider. So, if given a choice, what would you go for prophylaxis?
Yes, so many people or many authors have mentioned that phenobarbital or phenobarbital is a good choice, and also valproate, acid or sodium valproate is a good choice. Carbamazepine and phenytoin are certainly no. They do not offer so much benefit, especially in simple febrile seizures, which tend to be generalized. So if you have to use ASMs, then you have to think phenobarbital or sodium valproate. Again, it is important to remember that these drugs do not come for free. They come with side effects, and you need to be very careful in giving them out to a child who probably will not need it. Yeah. Especially if the febrile seizures are simple and are not causing any focal deficit, cognitive impairment, or behavioral deterioration.
Right. Thank you. The next one is actually a comment from Tahir. He says, thank you for this informative and comprehensive talk. In our part of the world, to have a thermometer at home is not common, and therefore it is not easy to diagnose febrile seizures, and thus any child with a seizure should be taken to hospital for verifying the diagnosis. We agree.
Sure.
Right. So the next question is, could you please elaborate on how the dying back phenomenon makes the 6 months to 6 year age group susceptible to febrile seizures?
Yes, so there is this notion that pruning or sort of during myelination, there is this pruning and some neurons need to be pruned, or some excessive networks need to be taken out. I do not know exactly how it makes the brain hyperexcitable, but it is believed that that process itself puts the child at risk of seizures because it makes the brain tissue hyperexcitable. I do not know exactly how it works, but the hypothesis is that because of myelination, and then the fact that there is some pruning or some reshaping of the neuronal networks, that puts the child at increased rates or makes the child susceptible to seizures with fever. Yeah. Sorry, I don't have the exact answers for this one. I think we'll all keep looking it up.
Right. So the other question is from Faraji, and he asks, does the definition of febrile seizures still include a seizure with the absence of metabolic imbalances? And he says, because Dravet has a sodium channel mutation, which usually is a metabolic derangement. So would you define that as febrile seizure?
No, I don't really get the question, but the definition of febrile seizure is that the child must be aged 6 months to 6 years. The child must have fever and must have a seizure. And I'm not sure about how electrolyte imbalances will come in here. The process of having a seizure itself will lead to a lot of acidosis, and will cause pH changes, and electrolytes might shift in and out of cells. So I'm not very sure about that, especially if the seizure is prolonged. Then it might lead to electrolyte changes or abnormalities.
Okay. Yes, so I think he was trying to ask whether if you have Dravet, would you still call that a febrile seizure, is what I understood, although the question is not quite clear.
Yeah, so in Dravet syndrome, they present with prolonged febrile seizures in the first year of life. So it is called severe myoclonic epilepsy of infancy, but actually in infancy, which is in the first year of life, they tend to have prolonged febrile seizures. The myoclonic epilepsy and then the myoclonic seizures and the other forms of seizures that follow are usually in the second year of life. But in the first year of life, they tend to have prolonged febrile seizures. Yes. So yes, we call them febrile seizures until we make the diagnosis of Dravet syndrome.
Right, thank you. So the next question is whether the term febrile seizure is a diagnosis or a sign. I guess maybe he wanted to ask a symptom.
Yeah, so ICD-10, I don't think has febrile seizure on the list. It will give you a whole list of diagnosis without febrile seizure. And so every child with febrile seizure, there is a reason for the fever. So in my part of in the hospital where I work, for example, a very common cause of febrile seizure is malaria. So you often see us make a diagnosis of febrile seizure secondary to malaria. Then we may have febrile seizure secondary to respiratory tract infection. So there is always an underlying cause, which should be the diagnosis. But then the child has also had a seizure. So the child may have an ICD definition, which may be either generalized seizure or localization-related seizure based on the presentation of the febrile seizure. So the febrile seizure in itself may not be a diagnosis. It's a more descriptive term. It's more like saying this is the problem that the patient has, but then there are underlying diagnoses.
Thank you. That's right. Still have a couple of questions to go. So the next question is, what is really vital in febrile seizures? Is it the anti-seizure medication or the antipyretics and rapid lowering of the temperatures?
So in many patients, they do not require anti-seizure medications because the seizures will stop even before they arrive in the hospital. Many of them will, only a few of them will require pharmacologic intervention. So yes, the anti-seizure medications are important if the febrile seizure is prolonged. But then for many patients who present with simple febrile seizures, the anti-seizure medication is not indicated. Then secondly, the antipyretics do not really alter the pattern of the seizures or the recurrence rate of the seizures. And the antipyretics, as I said, only make the child comfortable, and that is their only role in the whole illness. You lower the temperature, the child becomes comfortable. What is most important is the safety of the child in terms of the airway, the breathing, the circulation, and then the treatment of the underlying cause. And these are, for me, I think, is the most important approach to the child who presents with a febrile seizure. Making sure that there's no airway obstruction, making sure the child is safe, monitoring the vitals, correcting hypoglycemia if present, and treating the underlying cause. And let us not forget that it may be a complex febrile seizure, in which case there may be very severe underlying conditions, and the child should be properly evaluated, and then the underlying conditions are appropriately managed. For me, that is the important.
Yes, yes. Thank you. You had already answered the next question, which is on when to give diazepam, which is for recurrent prolonged febrile seizures. So we'll go to the next one, which is from Zamir. He asks, how do comorbid conditions such as developmental delays or other neurological disorders influence the approach to febrile seizures?
Yes, so I think we also talked about this previously. If the child has an underlying comorbid condition already before the seizures, then you should look at identifying these underlying comorbid condition. For example, a child who already has developmental delay or regression who presents with a febrile seizure, there may be an ongoing neuropathology which needs to be addressed. It may be structural, it may be metabolic, it may be infection or whatever. And that the seizure was only a trigger of the fever was only a trigger of the seizure in this child. And if that is what brings them to medical attention, then fine. But then there's still the underlying comorbid condition should be addressed. Again, if the child without an underlying comorbid condition presents with a febrile seizure and subsequently develops comorbid conditions like focal deficit or cognitive impairment or behavioral deterioration, again, it should be properly evaluated. That child should be properly evaluated, and then the underlying condition properly taken care of. So there are many conditions that could trigger a fever in a child, and the fever can lead to a seizure. But then again, children who already have underlying neurological problems have a low threshold for seizures. And so the slightest fever will trigger a seizure. And that's finding the underlying cause or the underlying comorbid condition and managing it properly should be key on our list.
Right. So the next question that is there is, what is a duration for the definition, for the ILAE definition of febrile seizures? Is it 5, 15, or 30 minutes?
Sorry, I didn't get that. You said a duration for
the duration, the ILAE definition of febrile status epilepticus in terms of seizure duration, is it 5, 15, or 30 minutes?
So status epilepticus is a completely different thing. Traditionally, we have said 30 minutes or recurrent seizures without regaining of consciousness. But more recently, there has been an update of this definition. So we are saying that there is a time T1 and then there's a time T2. And the time T1 has been set for convulsive status epilepticus, for example. The time T1 has been set to be 5 minutes, while the time T2 has been set to be 30 minutes. The importance of this is that you don't want to wait till the child gets to 30 minutes before you say this is status epilepticus, so let me kick in the protocol for status epilepticus. No, at that time, a lot of neuronal damage might have occurred already. So you want to kick in when the child, especially pharmacologic management, when the child gets to 5 minutes. That is why the time T1 has been set for convulsive status epilepticus to be 5 minutes. There are other forms of status epilepticus, which, for example, absent status epilepticus, the time T1 has been set to be 10 minutes. And then it is unknown for other forms of seizures. So it is still an area that requires a lot of studies. But currently what the ILAE has said about status epilepticus is that there is a time T1 of 5 minutes and a time T2 of 30 minutes. That is if it's a convulsive status epilepticus. I hope we have moved a little away from febrile seizures. We are now talking about status epilepticus, which are
yes,
but they can pair together. So I hope I've clarified it enough.
Yes, I think also he wanted to find out specifically about febrile status, whether we still use that or do we say 30 minutes for febrile status?
Yes, so it has not changed. Traditionally, it will be 30 minutes. So for you to say there is a febrile status epilepticus, it has to be 30 minutes. But as I said, the update of the definition makes provision for a T1, which is 5 minutes. That's time T1, which is 5 minutes, at which time pharmacologic intervention must be started.
All right, thank you. So the next question is whether there is an association between attention deficit hyperactivity disorder and febrile seizures.
I've not come across anything like that. I don't know. I've not come across anything like that.
That would be a good study.
I don't know if there is any mutation that will predispose the child to febrile seizures and also predispose them to attention deficit and hyperactivity disorder. I do not know about that.
Right. I think it's an area for more studies. So the next question. The next is, it says, thank you for nice presentation. My question is, can a febrile seizure occur with a low-grade fever such as 37.8 degrees Celsius?
Yes, it can occur. So traditionally, we have said 38 and above. Some have said 38.3. Some have said 38.5 and above. But there are children who may have very low threshold and may have seizures at temperatures as low as 37.8. The only difference here is that these children are at increased rates of recurrence of febrile seizures. Remember, the factors that predict recurrence include having your first febrile seizure at a relatively low temperature, and also a family history of febrile seizure, and then also short duration from onset of the fever to the seizure. So if you have it at a relatively low temperature, yes, it is still a febrile seizure, and then it actually puts you at an increased rates of recurrence.
Right. So the next question, the next person says, thank you for the presentation. Is there any clue that we can clinically diagnose Dravet syndrome versus febrile seizures other than with an EEG? And what is the long-term prognosis and outcome?
Yes, so the EEG is not a diagnostic tool. We don't use the EEG, especially for conditions like Dravet, because they may have very varied abnormalities on the EEG. The EEG actually helps us to properly define our seizures once you've made a clinical diagnosis of epilepsy. So for Dravet syndrome, clinically, they tend to have prolonged febrile seizures in the first year of life. Then subsequently, they have myoclonic seizures and other seizure types, which are intractable or medically refractory. And then they may have neurological deficits, including behavioral deterioration, including cognitive decline. And then if you do suspect that that is looking like a Dravet, you may then send DNA for analysis. So that will probably be the way to go. The EEG is useful. Yes, it will help you define whether your seizures have a focus, whether your seizures or what seizure types, especially if you can do a prolonged EEG with video telemetry. It can help you tell the various seizure types that you have within a period, but then the EEG is not diagnostic. You don't use the EEG to say, I'm using it to make a diagnosis of Dravet or a diagnosis of any other seizure, epilepsy syndrome. Yeah, I hope that answers the question. And then the second part of the question asks about the long-term outcome. So yes, Dravet syndrome has poor prognosis. Unfortunately, they tend to have cognitive decline, behavioral deterioration. So they are one of the syndromes that we call epileptic encephalopathy. So the more they have the seizures, or the seizures themselves drive a cognitive decline, and the more they go on, the worse it becomes. And so they tend to we tend to use many medications, polypharmacy in many instances, especially when we don't have some of these orphan drugs that are recently available in North America and Europe. We tend to use multiple drugs. We do polypharmacy. You may do the ketogenic diets in managing some of these complex syndromes like Dravet syndrome.
Right. So the next question, I think we've answered. It's about whether we can call recurrent febrile seizures epilepsy. No, because by definition, as we had said, epilepsy is unprovoked. So we'll go to the next question, which is interesting because the second time we've had a question about hyperactivity. So it's a question about whether if a febrile seizure is associated with behavioral disorder such as hyperactivity, is it still a simple febrile seizure?
Yeah. So okay. So it depends on what came first. If the febrile seizure is subsequently followed by hyperactivity, then by definition we say that there is a neurological consequences following the febrile seizure, and that makes it a complex febrile seizure. If the patient already has an underlying hyperactivity, I'm not very sure whether you want to say the febrile seizure they present is a complex or a simple febrile seizure. If it is still generalized, if it is of short duration, and if it doesn't worsen the underlying neurological disorder, I'll be very, very careful in calling it a complex febrile seizure. But again, I'm not very clear about this, and I will need an expert's opinion on that myself. Yeah.
Right. The next question is from Nelson. He asks, in the list of risks for the development of epilepsy from febrile seizures, You had mentioned neurological abnormality. Which abnormalities exactly are we referring to?
Yeah, so I mean, neurological abnormalities is quite broad. It doesn't really talk to any particular one, but it could range from focal deficit to cognitive problems to underlying behavior problems. It could range from previous insults like a previous stroke. Or so once there is an underlying CNS pathology and you have a febrile seizure, then you have an increased rate of subsequent epilepsy in later life. Even that means you can even have seizures even without a fever in later life. Yeah.
Right. Thank you. The next question is from Andrew. He says, greetings and thank you for the presentation. Are there certain circumstances in which the complex febrile seizures can affect development, and how would you proceed to support this child?
Yes, so the complex febrile seizures tend to affect the development. That is actually one of the criteria for classifying it as a complex febrile seizure. So we are saying that the simple febrile seizure does not have post-ictal sequelae, but the complex febrile seizure may lead to post-ictal neurological deficits, which may include developmental delays, cognitive deficits, behavioral deterioration, focal neurological deficits. So these could all affect subsequent development, and that is what actually makes us call it a complex febrile seizure. If these things are absent and the seizure is generalized, it is brief, and it's generalized and brief, then it's a simple febrile seizure. And again, if you have it only once within a febrile illness or within a 24-hour period, then that makes the simple febrile seizure. But otherwise, it is a complex febrile seizure.
And I guess we would support them based on the specific needs, yes?
Yes, absolutely. Yeah.
Right. So Harriet says, thank you for the great presentation. What are the indications of lumbar puncture in a child with an index febrile seizure?
So yes, we mentioned that the child coming with a very first febrile seizure should be hospitalized and closely monitored. Your greatest fear is a CNS infection, such as meningitis. So if the child is less than 12 months, as I said during the presentation, if the child is less than 12 months, then your index for doing your threshold for doing a lumbar puncture should be very low, because these children often do not have clear meningeal signs for you to say this is meningitis. Again, if the child has received prior antibiotics before coming to hospital, then that could mask the meningeal signs, and that should also lower your threshold for lumbar puncture. Again, if the child is between the ages of 12 to 18 months, we say that you should monitor them closely. So whilst we say that below 12 months, the lumbar puncture should be strongly or highly or strongly recommended, or I don't want to say recommended. It's the child should be closely monitored, and then if necessary, have a lumbar puncture. We say that the child between 12 and 18 months should be monitored also. Okay, but then the child over 18 months, if he presents with a simple febrile seizure and the focus can easily be identified, and then that child does not need a lumbar puncture. So to summarize, I would say that young age, less than 12 months, also prior use of antibiotics, and then when the febrile seizure has complex features, such as being prolonged or having a focality, or being repeated within 24 hours or within the same febrile illness, these are strong indications for doing a lumbar puncture. Let's remember that the lumbar puncture is quite invasive, and that you want to be very clear about doing a lumbar puncture. There may be contraindications to doing the lumbar puncture, such as cardiopulmonary instability, but that should also let me say that should also not stop you from treating the child as having meningitis. So if you have the slightest thought about meningitis and then the lumbar puncture is delaying treatment, you should proceed to treat without delaying or without saying that you want to do the lumbar puncture first before you treat, because the benefit of treatment far outweigh the risk in such children. Yeah, thank you.
Thank you. I think the next question seems not clear. Agnes is asking, do the febrile seizures include those in the neonatal period? She may be alluding to another, I'm not sure what that question is. Maybe you can retype it and then we'll get a chance to answer it.
Sure.
So the next question is, are there specific cognitive and behavioral tools that you can mention that can be used as part of assessment?
For the child presenting with febrile seizure, your focus is stopping the seizure, treating the underlying cause, dealing with parental anxiety, and then discussing the risks of recurrence and subsequent epilepsies. So I'm not sure what we mean by tools to be used at the time of admission. I'm sure it's probably talking about subsequent review. Yes. So any child who has suffered a catastrophic event needs to be monitored closely. And there are various tools being used in various centers to monitor development. So you probably will refer that child to a high-risk clinic where the developmental outcome is monitored. If you have a developmental pediatrician in your facility, it is important that you refer such children to them who may monitor the development of this child for a period. And then if they need to intervene at any point in time, they will. But the tools to use, I don't have any specific tools to use. There are many developmental tools that can be employed.
Great. So there's a question from Clement. He asked, is GLUT1 deficiency associated with febrile seizures?
So GLUT1 deficiency disorder is a disorder in which there is a defect in the glucose transporter system, and it results from, or it leads to having low levels of glucose in the CSF, and that provokes seizures. And those seizures may be febrile or afebrile, and they are often erratic myoclonus, and we will not call that febrile seizures. If the child has a fever and the fever triggers a seizure, then fine, if it falls within the category. But children with GLUT1 deficiency disorder often tend to have seizures even very early on. Sometimes in the first month or first 2 months, they may have erratic myoclonic seizures, and they can be very catastrophic, and they do not fall in the category of febrile seizures. So they stand on its own. However, as I said, a fever may trigger a seizure in this child.
Right, thanks. So the next question, I think, is a repetition in terms of prognosis of Dravet, but I think the question really is asking, how do you diagnose a patient who have Dravet syndrome versus having a febrile seizure clinically?
Yes, so the patients with a febrile seizure often do not have cognitive decline. They do not have behavioral deterioration. Even the genetic epilepsy with febrile seizure plus, they might tend to have seizures even beyond 6 years. Some have seen 8-year-olds, 9-year-olds who have fever and seizures. So they have fevers, and then the fevers will trigger a seizure. So, and then they tend to have the mutation of the SCN1A mutation or SCN2A or 9A mutation or the other mutations. We say they have Jeff's plus or genetic epilepsy with febrile seizure plus. If cognitively they do not have any disability, and they can function in mainstream school and then learn as much as all regular children do, and they do not have Dravet syndrome. The children with Dravet syndrome have cognitive issues. They have behavioral deterioration. They have cognitive decline. They have often difficult to manage seizures, and they will require many medications, polypharmacy, to manage their seizures. And the outcome is often, the neurological outcome is often poor. So that alone is a distinction between the two. But again, there's no clear distinction. As I said, it is a spectrum. At the mild end of the spectrum, you have simple febrile seizures. And then somewhere in between, you have the genetic epilepsies with the febrile seizure plus or the febrile seizure plus. And then at the extreme end, you have children who have Dravet syndrome. So the key thing here is that the Dravet syndrome has a classical way of presentation, which is prolonged febrile seizures in the first year of life, and then followed by myoclonic seizures, which are difficult to manage in the second year onwards, and then they have cognitive and behavioral deterioration following that. And they often require polypharmacy in management.
Yes, great. And just to add to what you had mentioned, for a child presenting with hemiclonic febrile seizures in infancy, then you really need to refer that patient. Yeah.
Absolutely.
Right. So the next question was from Sajan again. He asks, you have mentioned about zinc deficiency that may be a factor and that tests are not readily available. So would you recommend zinc prophylaxis? And if so, what would be the dosage?
At the moment, I will not recommend zinc prophylaxis. We do not have any such strong evidence to use zinc prophylaxis in children with febrile seizures. I'm not aware of any studies that have done extensive studies that have been done on this. It is only postulated that during a febrile illness, there is decrease in serum and CSF zinc concentration. And because zinc is a modulator of GABA synthesis, its absence leads to neuronal hyperexcitability. And that is has only been postulated. I'm not sure of any studies in human that have looked deep into this. And so it is premature to recommend zinc supplementation for a child with febrile seizures. Maybe one of us can take that study up. Yeah.
Yes. Right. So we have two more questions remaining. So the second last question is, could you comment about the correlation between iron deficiency anemia and febrile seizures?
No, I have not come across that in my reading. I have not come across that. Again,
maybe I can
yes,
comment.
if
Yes.
have,
So
yes.
there are a few studies. There are a few studies that show that in patients who have febrile seizures, they also have iron deficiency anemia. Yes, so it's there in some studies. Yes.
Okay. Thanks for that.
So, yeah. So there's a question from Siadash. She says sometimes parents said patients had fever after the seizure. So is this considered as febrile seizure as well?
Yes. So I think I mentioned that some patients will have fever after the seizure. It is difficult to tell that they didn't have fever before. But again, as I said, the most important thing or the most important trigger of the seizure is not the peripheral temperatures that we often check in hospitals or at home. It is the rate of rise of the core temperature. So if the core temperature of the patient rises so rapidly, that in itself could trigger a seizure, even though the patient may be febrile at that time. So some patients may be febrile at the time of the seizure, and then parents will tell you, oh yes, there was no fever, but then they in hospital in an hour or two, then they tend to spike fever. So it is possible, and we've seen a lot of that. So the most important thing is the rate of rise of the core temperature. If the core temperature rises so rapidly within a short time, that in itself could trigger a seizure in the immature brain. Yeah.
All right. We had mentioned that we'd be taking the last question, and I think it's a retype from Agnes. So the question that she had been asking before was, in the discussion, you mentioned that if a child has had a febrile seizure before the onset of a febrile seizure, then it is not considered febrile, it's considered epilepsy. So the question is, are the febrile seizures during the neonatal period considered while making that decision? Whether we are still considering febrile seizures in the neonatal period as epilepsy, I would
Yeah, so epilepsy can be diagnosed at any age, and some neonates may have recurrent seizures, and if they are febrile, we could make a diagnosis of epilepsy. So if such persons go on later to develop fevers and seizures, then it would be like one of the scenarios that I talked about, where they already have epilepsy, and then the fever only comes as a trigger of their seizures. So such patients may have febrile seizures, or let me not use febrile seizures. Such patients with epilepsy may have fever with seizures, okay, or may have seizures with fever, and then they may also have afebrile seizures. So what we want to do is that we don't want to call the person who already has an established diagnosis of epilepsy, who is now presenting with fever and seizure, as having a febrile seizure, because they already have an underlying diagnosis or an established diagnosis of epilepsy. But I'm saying that your approach to the seizure will not be any different from the one who doesn't have a prior diagnosis of epilepsy. You still want to secure the airway. You still want to ensure that circulation is good. You still want to ensure that the child is breathing and breathing is good. You still want to do the basic ABCs and then find the underlying cause. Once there is a fever, you find the underlying cause and then you manage appropriately. I think I hope I've answered that adequately well enough.
Yes, you have. And thank you so much, Dr. Hammond, for your patience and for the great presentation and for taking so many hours to answer the questions. We appreciate. For the last two questions, I just answered direct to the panelists. Okay. So we're coming to the end of our presentation. So there was a message from Prof. Gail Shah, just encouraging everybody to do the PET 1, Pediatric Epilepsy Training Course 1, which we highly recommend. So just to close, the Global Health in Epilepsy Project database provides a registry of existing epilepsy projects throughout Africa, the Eastern Mediterranean, as well as in other regions. It identifies information such as project location. Sorry for that. So the goals of the Global Epilepsy Project database is to increase collaboration, reduce redundancy, direct resources. It also promotes advocacy. It identifies volunteers and service opportunities, and it targets potential funding for future global health projects. So kindly visit the ILAE website and submit your project. So the website is as listed there at www.ilae.org, project database.